Welcome to the Fac Dev Lounge podcast, your DMNB podcast for all things faculty development. I'm Dr. Sarah Gander, a pediatrician in St. John, and your host for the podcast. Today, I'm excited to welcome Andrew MacLean, who's an old friend of mine from MBMS days, but now a almost finished medical student and thankfully heading back to his stomping grounds in New Brunswick to work, and we'll hear all about it. And today we're going to talk a bit about something that Andrew's old hat at, which is advocacy and current health issues. He's active on Twitter, and we'll get you, Andrew, to give us your Twitter handle so people can follow along. But welcome to the podcast today.
Thank you. Thank you for having me.
Finally, we get to do this. I've only been talking about it with you for months. Years even, maybe.
I mean, you're dating me now because you're telling me I'm an old hat, and we've been talking about this for years, and I'd like to be a spring chicken.
I didn't say hag, I said hat.
You're right. No, hat. Okay, well, and that's fair. No, all of those things are totally true and accurate. They're just, my hairline doesn't want to believe it. That's all.
Oh my goodness. Well, thanks very much for coming. Why don't you tell the audience a bit about yourself and your path to medicine and then back to New Brunswick.
It's a long and winding road, and it could take up the entirety of the podcast, but I'll be brief about it. So I'm an old guy who went back to medical school. I'm 35, and I'm done now. Essentially, I've only got a few more weeks left, of course, before I start residency, because as everyone knows in medicine, the learning never stops. But I grew up in a tiny town called Lawrencetown, Nova Scotia. There's two Lawrencetowns. One of them has a beach and is beautiful, and I grew up in not that one.
In the other one.
I grew up in the less famous, also named for Charles Lawrencetown. And it was a village of 400 people with a slow down light and one stop sign. And everybody contributed, and everybody worked really hard in the community and volunteered. And I think that's kind of where this whole medicine dream probably started. And I did the Renaissance College program at UNB, so shout out to UNB. And then went abroad and did my grad degree in health policy and economics in the UK. Came back and worked in Toronto for a number of years in healthcare consulting, and then went to the MBMS where we met, fatefully, to do some healthcare advocacy and lobbying and that kind of stuff. And then I looked around when I was 30 and said, am I going to do this for another 40 years? Because I've been doing it for 10 years. And I decided to pull the trigger and leave my loving wife and children and go back to medical school, which, as you can imagine, was a great, well-received decision by everyone involved. And now I'm done my undergrad and hoping to be a family doctor and hoping to be in New Brunswick. But I will say I can't count my chickens because the match hasn't happened yet. So while I'm hopeful to come back to the East
next
Coast,
week, right?
Nothing is guaranteed. It's next week.
Yeah,
so
at the time
I'm
of
in
this
that
recording,
fateful
it's
no
next week.
person's land between having graduated and yet still not having any idea what I'm going to do.
But by the time this podcast probably launches, we'll know.
We'll either be celebrating or crying. And well, there'll be tears on both ends, really. That's how I roll. I'm crying for everything. But that's the hope. But no matter what, like, I'll still be doing some healthcare advocacy stuff. And I've done that for a number of years now. And I continue to do it. I find it a lot of fun.
Why do you think healthcare advocacy is so important? Like, as a physician or not?
So it's hard for me to distinguish that because I wear so many hats. So the healthcare economist in me says, for every loonie you give me, we take two of the quarters of that and spend it on healthcare. And so if you're interested in the environment or education or public safety or any of the other things that government can do, you should be worried about how much money healthcare takes from all of those things. And if you're interested in healthcare, you should be very concerned about how that healthcare dollar is spent, that proverbial 2/4 of the tax dollar that we take. If you're a patient, I think people have all kinds of issues with the system, but also just trying to maintain good health for yourself can be better achieved when you're connected with a good team of people and you're working in a system that navigates and communicates well. And then I think if you're just a general citizen, you should be interested in one of the things that, for better or for worse, has defined us as Canadians in terms of our ability to look out for one another and be cautious and thoughtful about how we provide for one another. And so now I have this new hat as a doctor, and I'm curious about it in terms of how we as healthcare providers work together and how we care for patients. But I guess I come at it from so many different lenses. So I think that advocacy piece is really just about expressing what it is you wish for and then leaning against the wheel, like, and pushing really hard to try to achieve that. Because it's one thing to gripe, but it's another to work. And I think it takes both things. We need a good gripe every now and then, but we also need people that are willing to stand up and be counted and do the work.
Well, I think as physicians too, we have this unique sort of privilege of being in a position where we know exactly what the patient, well, as close as we could without being a patient ourselves, patient experience, because we're, walking that path alongside them at times. And then I think from a faculty development standpoint, I thought it was really interesting to have a conversation about how we can mentor and help our students kind of build those skills, because I think as healthcare providers, we do have a voice that can make an impact. But I don't know, do we do a good job of teaching students how to use their voice, or how to comfortably use their voice, or feel like they have a seat at the table to use their voice? I mean, I think these are things that you might have some thoughts on, just in terms of even curriculum for students as we're moving forward.
Yeah, so I went to the big bad McMaster University, so I can't comment on how well Dal is doing. And you could tell me wonderful things about what Dal is doing. And A, I'd believe you because I don't know any better. And B, I'd also be really encouraged to hear it. But one of the things I learned so I have a number of roles in the past, in addition to being a healthcare advocate. So I worked a lot in the system in which we organize primary care and electronic medical records. I've worked in the business of healthcare, so the for-profit, real, looking for money business of healthcare. I worked in all kinds of spaces. And one of the things that I have found unique about doctors is that they're always the problem. And so by that I mean, in any healthcare organization I've ever worked, in hospitals and regional health authorities and so on, it's always the doctors who, they don't support us, they won't come to our meetings, they don't believe in what we're doing and so on. And I remember thinking when I was pretty young in my career, like, geez, I really want to go work for those doctors, because no matter what, they're always the problem. Like, it's universal. It's incredible how problematic those doctors really are. And when I get in and sort of understand that when meetings are conducted at the regional health authority or the hospital from 10 to 12 on a Monday morning, right in the middle of clinic, or when doctors are having trouble justifying spending that time in meetings where, as once it was told to me by another physician, meetings are the places where minutes are taken and hours are wasted. It's really hard for doctors to justify that time. And getting into medical school, one of the things I was really hoping for was that medical schools specifically, would have done a better job in teaching doctors, not only the clinical ends of medicine, which is the primary goal, of course, but also how to be effective in terms of the leadership work that doctors do, or the advocacy work that doctors do. Because I'm not sure what it's like in St. John, but in many places that I've come across, the person who gets to be chief of the department is sometimes the last person out of the room. Nobody wants to be chief.
Or they didn't come to that meeting, so they were voluntold.
Totally, yeah. The person who didn't show up ends up with a 5-year commitment, right? So it's not necessarily how do we make those roles attractive, but how do we give people those skills, right? So advocacy is more than good tweeting, although that is a skill that I wish more doctors would employ. It's also about understanding how the healthcare system spends money. It's about how do I be effective in a meeting? It's how do I engage patients successfully in a nonpartisan manner that's outside of the office and outside of the clinical encounter, but leverages the responsibility and the reputation that I have in order to influence healthcare in a positive way. So I was hoping that we would do more of that in the medical school that I went to, and I'm hoping Dal is a stellar example. But I will say that generally studies show that medical students come out not well prepared in the realms of advocacy skills. And so they often understand and can see lots of problems, but they don't necessarily know what to do in terms of how to face those problems and confront them. And I think that doctors generally have learned this through the hard way because they necessarily weren't taught those skills themselves. And I think it's super important to help to teach those skills. And I have a bunch of ideas, Dr. Gander, as how faculty can do that.
Oh, that's amazing. I think, too, that just a shout out to the podcast that we recorded before this with a couple of students. We were talking about electives and elective experiences and building capacity more than just, a student's coming or a learner's coming to work with me and I'm seeing X amount of patients, but rather thinking outside of the box. And, well, the examples I gave were like bringing them to court with you, or like bringing them to, when I was department head and I'd have an elective student, you kind of pick and choose the appropriate meetings that I would bring them to so they could watch even that dynamic between physicians and administrators and just how the process goes. And then they would ask a lot of questions that, it can be frustrating, but at the same time, at least they're getting a glimmer into why some of the things happen the way that they do. The not so hidden curriculum, but, things that you don't know until you kind of get out there and get into those roles. So awesome. So let's talk about some of the ideas you have.
Yeah, so there's so many skills that we teach medical students along that line that just take a bit of tweaking. So when I think about advocacy, I think about kind of small A advocacy. So the kinds of advocacy that we impart to medical students in terms of how to advocate for their patients. So this is things like system navigation or speeding up that referral by giving the phone call instead of sending the fax and so on. We teach them all of those things. We teach them a lot about social issues. I think that's very different than it once was. And we also teach them about communication with patients and how they can do that really well. We don't necessarily teach them how to do that on a broader scale. There's some famous quotes there, but the idea of how we use those skills in other ways. So, one of the things I think it's really important to understand is that understanding the context and the system in which we provide care helps us be a better collaborator. So in thinking about the CanMEDS roles, everybody loves a good CanMEDS role. Everyone has their favorite. Can't pick one, like a Lay's chip.
Mine's advocacy.
There you go. I
Or
thought
maybe just
advocacy
storm
was too on the
chips. Maybe
nose
it's
to
like
start with.
storm CanMEDS. It's all of them mixed together.
Right.
Is that
yeah.
like the cheesiest answer ever?
I've just come out of the match process and you have to do that interview and they always say like, which CanMEDS role is your favorite? And the
They do
obvious
not
answer is
ask
just
you
like,
that.
all of them. My kid will say, what's your favorite color? And she says rainbow. You just have to pick all of them at
It's like,
once.
what's your
Yeah.
greatest fault? I'm too organized.
I work too hard. Yeah, I just love too much. I love too much. So understanding that context makes you a good collaborator, right? And so that goes in all kinds of ways. So understanding how people are paid is very important to me as a former healthcare economist. And that's actually the context in which we provide care. And advocacy around those things is really important. So if you're going to be a collaborator in a community health center, so a community health center in New Brunswick is a place where usually family docs work with a team of other people. So they might have a social worker and nurses and so on. That's going to be a different type of practice than if you're working on your own in a fee-for-service practice. So you don't necessarily have a team of people around you. And understanding how those people work together and how they don't work together, the role of unions in that healthcare environment, the role of understanding who has a choice of picking who. So if I don't love the receptionist at the front door, is there anything I can do about that? Or how do I approach that conversation in a thoughtful manner in terms of where that person is coming from? That's really small A advocacy kind of stuff, but you got to start with what's around me and what do I actually know? And teaching medical students the basics around what is the context in which we're all working together here helps them navigate that system in which they're going to work, right? Even things like information systems. Everybody loves a good electronic medical record. And why don't they talk to each other? And why doesn't my healthcare, when I swipe it, contain any information at all? It's just a magical magnetic strip on the back of a homely looking Visa card that doesn't have any information on it. There's no medical record attached to that. So helping medical students understand that, right, helps them understand that context. So when the patient says, oh, I was just at the hospital, I'm sure they have all of my records, and you're in the community and you might not have that, it helps them understand, why don't I have that? Like, and if I'm going to advocate for that, who do I even talk to about that, right? So it's trying to explain those questions that we deal with every day. I have to write this down in this wing of the hospital, and over here I can type it, and over here I have to dictate it. Helping them understand those things is actually really important to teach medical students as to why things are the way they are. Right now, just coming out of the COVID-19 epidemic, we have a big conversation, as we've had for a number of years, I guess, in a more slow burner way, about scopes of practice. So one of the groups of allied health professionals that went above and beyond during the pandemic was pharmacists. So pharmacists end up delivering the vast majority of COVID shots in New Brunswick and actually across Canada. And when you look around, it wasn't that long ago that we were fighting about whether or not pharmacists should be allowed to administer needles of any kind. And that wasn't that long ago. So helping people understand, why is it that the pharmacists are doing the vaccines instead of other people? Those are all things that we can explore as stories to talk about with medical students that help talk about what are the roles for scopes of practice and what's the responsibility of physicians in that conversation, and what are the things that we're sometimes tempted to do that we should be careful of when we're talking about scopes of practice. So those are all around collaboration, right? How do we work effectively in teams? How do we understand the environment that we're in? And if you're going to advocate as a medical student, it helps to, sometimes medical students are kind of like that race car that we have at home that you pull backwards and it kind of like charges the wheel, right? And then you let go and it flies off across the floor. You got to make sure that you're pointing well, right? That's the thing. Sorry if all my conversations relate to my children, but you got to make sure you're pointing well.
I'm a pediatrician, so
you're a pediatrician.
Point
this is
taken,
perfect.
right?
You
And
totally...
a mom of boys, no less.
Yes,
so
right. You get the race car
the
analogies that I make.
Yeah,
right.
a little bit.
So you got to point them well, I guess, would be the point. And the idea is that understanding the context in which you work is really important. And having those conversations with medical students around why things are the way they are is vital.
I think it's like a huge piece of, I don't love the word burnout, but I guess just sort of changing your viewpoint in how you see the system and how you work within the system. Like I do a bit of coaching, and when I talk to people, there's a lot of sort of not learned helplessness, but just sort of this helplessness feeling that you're at the mercy of the system and the process. And it's always helped me to at least sort of understand it a little bit more. It like opens the door to some compassion, but also some strategy for advocacy. So like something as simple as people don't understand why I don't know when their kid goes to the emergency department.
Mm-hmm.
They're like, we've been to the emergency department 3 times and
Right.
you haven't called us for a follow-up. And I'm like, I have no way of knowing that.
Right.
And then saying to somebody, the only doctor that's allowed on that sheet is your family doctor. And so then can we add another person? Can you ask for it to be sent to somebody else? Can you ask for a photocopy of that and bring it to me yourself? Like whatever. And you just sort of think like there are solutions to problems, and medical students and learners and young physicians and, anybody really who has the energy and passion could really solve some of these very figure-outable problems. Right. But not if you are just sort of saying, well, this is crazy. Somebody else should figure this out.
Yeah, and I think we do them a bit of a disservice sometimes by teaching them all about the problems and not a whole lot about how to act on those problems. So you can imagine the cognitive dissonance if we talk about what a crushing problem homelessness is, for example. And we don't really have good, effective ways for folks to actually work on that issue. Instead, it becomes something that you sort of accept over time, or at least the vast majority of physicians accept. And not understanding that actually even those little things, even adding the box on the form or changing the pronouns on things. There are all kinds of little examples of how improvements can be made. And physicians are in this unique spot that you talked about before, that they can see things sometimes because they work in so many different environments and they have so many patients who come across just stories that were never thought of or patient journeys that were never even contemplated when a certain care process was designed or just sort of arrived at itself. That other people don't see. The CFO of Horizon or Vitalité is not going to see that in the same way that physicians sometimes run across these examples of ways in which things can be better. So working on those things actually is kind of just as important and gives students and residents and young physicians a good place to lean in, like a good place to cut their teeth on some of those things, like dealing with processes that are bureaucratic or tricky sometimes. That help to prepare them and teach them more about, okay, if I can navigate this and change this form, maybe I can start to think about how I might navigate, a city council if I'm talking about a municipal issue, or writing to my MP if it's a federal issue. So those small opportunities to practice those skills are really vital for younger physicians.
Oh gosh, that's so good. So, okay, that was only one CanMEDS.
Okay, all right, that was one CanMEDS. We're going to be here all day, Dr. Gale. I'll speed up.
I told you it might be a 2-parter, but
it's tough when you're from Nova Scotia to stop talking. So the other one is around communication, right? So physicians as great communicators, and I talked about this before. So we spend a lot of time, I think, in medical school, or at least I did, on the role of being an excellent communicator. So that old rule around when you're taking a history, if you let them go past the 13 seconds or whatever it is that physicians often interrupt people at, they'll kind of tell you what their diagnosis is 70% of the time if you just let them talk. And that the history is the most vital part, right, of the patient clinical encounter. So communication is really important in that clinical context, but understanding how to sort of listen to the world around you and what it's telling you about what might be present in patient care is very important. So I'll pick a medical example and a non-medical example. And one that's close to your heart is around poverty and trying to understand, even from a social pediatrics lens, the role of poverty in patient care. You don't necessarily have to come out and ask somebody, or do you have a low income? Like what are you struggling with right now? And sometimes patients will just tell you, I couldn't afford to get here last time, or I can't afford my pills. But most of the time, they're not going to come out and tell you that. So that role of listening and communication, and then translating that forward. So if you understand that you have patients who are of a low income and that's impacting their ability to be healthy in a number of different ways, and you're coming at it from a healthcare point of view, one of the great examples that exists out there was a group of doctors actually looking at this together and coming up with a process and a pattern of how to deal with that. And that can be evidence-based, as physicians often love to do, which is to study sort of what are the words that I need to say or what are the things that I need to do to be able to address this issue effectively with patients. And so New Brunswick has this toolkit. I think it's called a clinical toolkit for poverty in primary care or something to that effect. And that's a piece of advocacy work, right? So that's a toolkit that basically says if a patient comes in and they have a low income, here's the question to ask to be able to suss that out, and it has sensitivity and specificity with it. And then here's what you actually do about that. So it's one thing to say that someone is not doing well from a financial point of view, but understanding how it affects their health, what it puts them at increased risk for, and then what it is that they need what it is that you need to do to help them with that is really just a good example of strong communication with your patients. And so that kind of comes from hearing that story and understanding what that means in the clinical context, and then working together on the tool to actually figure that out. Another story that's really topical right now in the non-medical context is the conflict in Ukraine. So the reason I bring up the conflict in Ukraine is not that I think New Brunswick can fix the conflict in Ukraine, but it's because as doctors engage in current affairs and think about what's happening on the news and think about what's happening in the media, you might understand, for example, that if you have a patient that you know is of Ukrainian background, right now is going to be a tough time for them, right? And that might seem obvious, but actually thinking that through. So what is it that I can do for that person right now? Are they trying to bring somebody into the country? Are they struggling with depression? Is this an adjustment disorder? Or is this something that could be longer term? What is it that I can do for them in the clinical context that actually might be helpful? Is a small form of advocacy. It's a small form of working with a patient to achieve a goal, but it's really around communication, specifically listening skills that we're doing there. So I think that piece helps us be better doctors if we are aware of what's happening in the world. And I'm not suggesting that we spend hours a day on The Economist or the BBC or other less old white man publications. If there's things that we can listen to or things that we can watch in the world to help us be better at our individual day-to-day role, that's part of being informed. That's part of understanding what's happening in people's worlds. So that's around communication and how we listen and how we work together and talk. And then one of the other things that I think it's important to understand from a current affairs point of view is that, New Brunswick has all kinds of, and Nova Scotia and PEI and Newfoundland all have healthcare plans and things they're trying to do in the healthcare system. And sometimes this comes to us in a brand new survey about something that we've never heard of before. They want us to opine on. And sometimes it's in the news that all of a sudden they're going to recruit 100 new family doctors, and we're not quite sure where they're growing these people. They may have the field out back where we're growing more that we just didn't know about before, right? But understanding what these plans actually look like and what they mean will impact the practices, right, of medical students as they choose their career. So if you know and you're really concerned about the role that artificial intelligence will play in medicine, you might want to think very carefully about your future career choice in radiology, perhaps, right? That's something that will impact the practices of those folks. I'm not saying there won't be radiologists. I'm sure there'll be radiologists in the future. But how will those things around current affairs and what's the New Brunswick government doing around that kind of stuff impact that world, impact those specialists? If you are of the opinion that family doctors are quickly being replaced by nurse practitioners and pharmacists, you might want to think about what it is your role will actually look like as a family doctor, right? So having those conversations with medical students is really important to affect the professional lives of those folks as they look forward to the next 4 years in their career. So this is around professionalism, right? How folks organize their careers, make career choices, organize their offices and so on, and how they live in a professional manner and how they make their choices of a professional manner is not just about patient care, really, but it is about how that world will influence them. So New Brunswick, for example, in its recent health plan, had huge suggestions on access of patients into their own medical records. And we talk about that with medical records with medical students. Don't write SOB when someone comes to the emergency room, no matter how hard they're breathing. We have to be careful, at least write SOBOE, so it's somewhat complicated for normal people to understand. But we don't want someone thinking that you cursed at them for their diagnosis when they came into the ER, right?
Oh
We talk
gosh,
about those things.
The PEDS example of that is I'm
Oh,
old enough to remember the FLK,
I don't
the
know what
funny
FLK. Oh, funny
the
looking.
funny looking
Yes.
kid who
Right.
would have
Yeah.
been, you know, do they questionably have a genetic syndrome or something? Do they have
Right.
obvious physical dysmorphism?
Right.
So if there's my cringy moment for the
The
podcast,
FLK. Yeah.
right?
Right.
Because people can figure that out. You just, well, what does FLK mean on a hospital chart? You Google that, it'll probably come out.
Right. Sure would. Yeah.
You're not making any friends that way.
No, I'm afraid
Because
not.
all
Yeah.
kids are cute.
All kids, you know what? One of the things I love about pediatrics is when you round in the morning, the first thing you have to do is talk about how cute the kid is. It's like vitals, and then, oh, he has the most beautiful nose. And then on to the rest of and it's just sort of like, I would never do that in any other form. I'm there in physiatry, I'm there in geriatrics. Mrs. Martin is, she's vitally stable, and she has the sweetest wrinkles, the sweetest little wrinkles.
Gorgeous. She's
And this
gorgeous.
chubby little bum, just stuff that would never fly
That's
in
totally inappropriate,
any
actually.
other form of medicine. But peds, it's just par for the course. God bless
Yeah,
you,
even with the
pediatricians.
tone, you have the cutest little bum.
Totally.
That's
Yeah.
not
Has the
appropriate at
sweetest little, yeah. We don't start with those in other forms. Yeah, thank God for
Well, it
peds
also means
keeping
we
us
can
humble.
justify market research, like playing Candyland and reading Twilight novels, because we need
Right.
to
You
understand.
got to know that. Yeah. What are the
We need to
latest
understand our
developments in
patient.
Candyland? A game that changes over and over as time goes by. Who knows what they're doing with Candyland now? But so the idea there is around understanding sort of what that context is, and understanding that you're teaching about professionalism in a way in which that folks find really important. And going back to funny looking kid, the New Brunswick government in its last health plan said that basically one of the goals they want is for everybody to have digital access to their health record. And so we've talked about being careful about what you write in your health records for a very long time. But when you are saying to medical students, no, they guaranteed will see this. It's not something that is going to be there if they requisition their health records through the dusty health records department at the basement of the hospital. It's, no, they're going to be looking at it on their iPhone tonight when they're, done watching Netflix. They're going to see what you said about them. So that impacts the students' professional choices in terms of how they're doing that, and understanding that that's the government's plan, and that's not something that physicians are going to be hey folks, remember to make sure that you're writing good vocabulary from here on out because your patients are going to see your records. That's really something that we've got to teach students really early on in terms of the world of professionalism, what that looks like.
Yeah, I have done a millennial talk over the years, and there was a study that I found that was surveying medical students about whether or not they felt like social media posts on their personal profiles actually reflected their professionalism at all. And when you combine the not at all or not really, sort of 80% of students didn't feel like what they posted on social media showed them in any sort of light. And now this would have been a couple of years ago now. And I just find that so shocking that I think too, students also, there's like their professional life and then there's their other life, and ne'er the two shall meet if they don't choose to. But it's also professionalism as yourself as a whole identity, which is really what you're signing up for in a lot of ways. It only takes one glass of wine at a restaurant downtown for a patient the next week to say, saw you at Italian by Night the other night. You like red wine, do you? And it's not meant to be a derogatory thing, but you are under a bit of a microscope, or people notice at least your behavior and take note of it.
Yeah, and you're in the massive metropolitan, cosmopolitan city of St. John. I mean, just imagine us
It's
poor
buzzing.
folks out in here in the boonies. And I have to say that carefully because I'm currently in Fredericton and my wife will kill me. But I remember vividly actually meeting my family doctor when I was quite young in my small village. He was by far the richest person I knew because there was no one else anywhere in town who would make anything more than $30,000. That was just astronomical money to us. And I remember spying on his shopping cart at the grocery store.
Ooh.
Like, what's this guy eating? He's
Chicken
got those
nuggets.
posters in his office about the vegetables. Does he get the celery? Is he really is he walking the walk here, right?
Oh
So,
my God. I
maybe
don't know
those
if
days are
that's in my
past. Maybe
shopping
they're
cart.
not. Yeah, don't look at my shopping cart.
Especially last week when I had COVID. My
Don't you
God.
dare. No, stay out of my ice
Couldn't
cream
taste anything, so
preferences.
everything had to be processed, so we felt like we ate something.
Right. But at least they're surreptitiously hiding things in their grocery cart and not sending tweets. Maybe after that glass of wine at Italian by night, that might get
Right.
you into trouble, right? I actually feel like that's a large part of what we do teach medical students. So I had a lecture on Twitter, because we do that now, and how to use Twitter. And most of it, I'll be honest, was the medical school saying, don't use Twitter, because you'll get yourself in trouble and you
Oh,
don't
just
know
like
what there is to tweet
abstinence.
about. Just stay
Just like
off it.
no, so
Don't have social media. Yeah, the lecture on how to be careful around social media was don't have social media. Like, change your name, put up a profile picture of the Calgary Flames, like be anonymous, just have your friends know you and no one else. And so we actually kind of scared people from engaging in conversations for fear that there's some risk associated with it, or, my views are not that of my employer, those sorts of things. Instead of actually giving people some advice, as I say, on where to point the race car, and how to do that effectively. So I think there are some skills that medical student associations work on. So I know that the Canadian Federation of Medical Students, Canadian Association, or I guess it's Resident Doctors of Canada now, those sorts of things, work on skill development with medical students. But we don't do a lot of that, I think, from the university level about how we actually teach that stuff. And I've worked with all kinds of physicians who believe that the number one route to advocacy and change is just calling the newspaper. Like, they'll never know what we stand for unless we call the CBC and tell them about this egregious thing that's just happened. And most physicians aren't aware that there's a whole ladder, right, of things to do that start small and start privately and start quiet, and you can sort of escalate from there. And in fact, once you sort of hit the nuclear button, with going to the media and talking about that kind of stuff, there's not much more you can do after that. You've sort of blown all your cards. You've laid everything out on the table. And so helping medical students understand that there's some escalation in terms of how that can work, and you don't start there, you start a lot lower or a lot more simple, can actually help folks develop a toolkit, like a whole cadre of skills that they can use to influence, to win winfluence, yeah, right, to win friends and
Winfluence. I
influence
love
people.
that.
As we want winfluence.
Winfluence. We just made a new
Winfluence.
word.
You know what? If you talk fast enough, you'll come up with some dingers every now and then.
Oh
Yeah.
my God. I'm putting
To
that in
influence people.
tonight.
There's a whole skill set of things that develop before you actually call the paper. And that's still a tool that works, but you want to make sure that you have a bunch of other things that you can do before that. So that's around advocacy, right? That's around the CanMEDS role of advocacy in terms of developing a suite of skills that include letter writing. They include how to have a meeting with someone in a professional context. What is an agenda? Why do we have to sit through these minutes and when the hours are being wasted? How do we engage in that with that suite of skills? Because very often we don't really teach doctors how to do that. So how do you know what you care about, right? As a medical student, like, how do you know what's your issue? Assuming that you're not going to try to eat the elephant, and you want to do one issue at a time instead of trying to bite it all off and fix world peace, I don't know if you can fix world peace, maybe create world peace. Fixing world peace sounds like it's a problem to be solved. Then what are those things that you care about? And then how do you engage on those issues? And teaching medical students to think small and think about what it is that they're personally passionate about is something that I think will help influence their practice choices, but also help influence what kind of advocates they want to become. So I think that's around those skills, and developing those over time. And that's something that, like I said, some subsidiary organizations are trying to work on, but I don't think there's a lot of doctor classes that actually teach students how to do that well.
I think too, like there's our modeling and our mentorship, and I've certainly had success with advocacy, and I've certainly learned some hard lessons trying to be an advocate. And those are probably stories we need to tell, not to spook people or scare people, but rather, if I had known then what I know now sort of situation. Even just media training in a way is a helpful thing, even outside of when you talk to media, because there's just a style of conversation that you can have. It actually works well in like a courtroom. Like you're just talking about the facts, or you're just talking about what you do know. And if people ask your opinion, that it's stated as such, that it is your opinion, things of that nature. And I think that the students would do well by that, because they are powerful advocates. We look for, like, they have their, I think it's actually called Advocacy Day, and the students do a really nice job with it, and writing letters to the MLAs or MPs and stuff like that, and really taking on an issue that's sort of their baby. One year that I was involved, it was youth homelessness, when they had closed the youth shelter here. And they did a really, really nice job, and really took, they didn't need a lot of counsel, but it was nice to be able to just say, like, I've experienced this before. Make sure when you go in, you're ready and you do this, and hopefully that was helpful. So I think there is a role for us to play. I wonder how it would go then if we had sort of like classes, or if that was a more formal part of the curriculum. Maybe if people weren't ready, or they didn't have their thing yet, or their issue, then it would be hard to kind of understand. So it's almost going to have to be a ready when you need it kind of situation, to sort of help students.
Yeah, I think there's a whole bit here obviously I'm passionate about it, and I got to be careful, because the nephrologists always want to have extra 1-hour sessions on the kidney for those of us who really care. And I'm conscious that I've never gone to any of those sessions, right? So you don't want to be that guy or gal who thinks their stuff is really cool and really important, deserves lots of time, and end up being a nephrologist. God bless you, kidney doctors. But I think there's a couple of topics in there. So one is the unique role that doctors have in our society in terms of advocacy. So people look to doctors for certain things. They don't look to them to be loud and loudmouthy. There's lots of people on Twitter that can do that for a cause. They don't need to be politicians about stuff and give answers that a politician would give, but they do tend to be really good at facts and evidence, and also quite nervous in terms of showing up in front of a camera. And I think actually quite a bit of people actually understand that. Like, if this doctor's actually talking about this on the CBC when they so clearly and evidently don't want to be here, they think that that's really important, right? This is not something that somebody called them and said, "Oh, great, like I get to be on the news." Like, totally, let me PVR it for another dated reference, right? It's really about how do we maximize the use of that time. And physicians have this really unique role that they don't, many people don't get to hear from other people in the healthcare sector. There are a lot of folks now who are bound by all kinds of rules in terms of confidentiality and communication. And doctors, of course, have some responsibilities in that realm as well, but generally are able and are thought to by society have an important role in identifying issues when they're there. So I think it's the role that doctors have is really important. I think it's the translation of skills. So I talked about this before in terms of how we teach doctors certain things in clinical environments, and really we just need to tweak them a little bit to apply to an advocacy environment. So I'll give you an example. Dr. Gander, that you're very familiar with, okay? And it's the doctor way of talking about stuff. So we do this all the time in the doctor's lounge, and the classic line is, "Well, I have this patient who," right? We always say, so talk to me about how doctors are funded or EMRs work or whatever that. Well, inevitably it comes down to a singular patient story. Well, I remember that one time that I had Bill, and he was a 45-year-old man. And when we start with clinical cases, even in medical school, it's like, Jill is a 75-year-old woman who came in with shortness of breath and so on. And then when we get in front of the news or we advocate to politicians, we do the doctor thing, which is the exact opposite of that, which is we say, here's what the problem is. Here's what our options are for dealing with that, and here's my recommended solution. And doctors don't bring people along to say, okay, if your issue is, bed days in the hospital and how high our ALC rates are, we say last year there were 45,000 extra days, there were, length of stay excess that we shouldn't have had, and we focus on the facts. And what we should do in an advocacy environment is actually what we do with other doctors, which is to get attention to say, well, you know what? I had this patient the other day. She's an 85-year-old lady. She came in for surgery. She came all the way down with her son who had taken 2 weeks off of work, and she was really nervous about it. And she got down that morning, and I had to tell her that her surgery was canceled because we don't have beds in the hospital. And now let me tell you about ALC and how it impacts the care of patients that I have. And all of a sudden, regular people can understand what it would be like to get ready for a surgery, to have your kid take the day or the week off work, to be really nervous about it, and then have that postponed, and how devastating that would feel.
And like
And
no
so,
idea when it's going to happen or
and
how
have
we're going
no
to
clue when it's going to happen,
plan
and have
for
the
it or,
and
yeah.
be the doctor in that story who has to say, by the way, I've canceled it, or it's been canceled. I can't really tell you, it's not my fault that it's canceled. I can't tell you when it's going to happen, and be left being that bearer of that news and what that's like. And so in an advocacy world, explaining those stories and talking people through those things is actually really important. And doctors do that with other doctors, but we tend to just focus on facts and clinical evidence sometimes. And we need to be a little bit more personal sometimes in the media about how we
I
explain
love
things.
that.
So it's just tweaking that conversation, right? And turning that around a little bit. And I think helping medical students do that. I think there is a little course in there somewhere, but I don't want to be that boring nephrologist.
Well, and I think it's one of those things too that like if we're going to address the CanMED rules as a holistic sort of approach to curriculum and constructing, the student the way we kind of want them to be in the world and have all of these things, then it is important to be overt about it, and not just assume that they're going to pick things up or like assume that, well, some people are advocates, some aren't. I would argue, maybe you will too, that everybody is an advocate, whether you call it such or not. Every time you pick up the phone to call a consultant for a patient, every time you spend a few extra minutes with somebody, every time you, put a sign in your office that says, what is your pronoun? Every time you kind of just step outside a little bit to do a little bit more, you're being an advocate.
Yeah, and I think there's that small A advocacy that we do every day that most doctors would say, I didn't get into this to be a social justice warrior or to be a big A advocate or to be a politician, right? Or those sorts of things. But many people, in fact, did get into this to go the extra mile for patients. They did get into this to be helpful beyond what it is that could have been expected. That's sort of what we wanted to do, I think, when we got into school and what we were trained to do. And that small A advocacy, those little things here and there really do add up. It's not the case that everybody's going to be manning the megaphone at a march, right? And in fact, most of us probably shouldn't be manning the megaphone at a march. But all of us have those skills that we can translate. And medical students are the most observant people in the world. They watch everything that you do as a faculty member at medical school. And they decide what kind of doctor they want to be from your work. And they decide what it is that you do that they don't want to do. And both of those lessons are equally important for medical students. What's the doctor I want to be? And what is it about this doctor that I don't want to be? And so using those examples are very instructive.
What if they don't agree? What if it's like a total, especially there's been some polarizing views, very, very challenging in healthcare because, there are people who just don't agree, with something that like for you and I, because we're like-minded in a lot of ways, that people be like, I have no business asking people if they have trouble making ends meet because I'm not a social worker, like full stop.
Yeah, well, you might think we agree, but you're from St. John, which makes you a deck worker on a boat somewhere. And I'm from Fredericton, which makes me a snob who doesn't think anything other than people from Fredericton exist. So yeah, we're only as friendly as we are bounded by geography. Let me pick on the two really easy issues then of medical abortion and medical aid in dying. Okay.
Yeah, so easy.
Those
Very
are the
cut and
easiest
dry.
issues I could think of. I couldn't think of any others. Both of those things are pretty recent in terms of their recent past. So you'll excuse me by saying that medical aid in dying in Canada, at least, is a fairly new development. It's been around for a while in other forms, but at least in Canada and legally, it's pretty new. Medical abortion, as distinct from surgical abortion, is also fairly new in Canada. It's been around in other countries for many years. And so we might not agree by virtue of our health position in terms of you're a social worker and I'm a doctor or something, but we also might just plain not agree on the issues at hand and our moral beliefs around what those are. And it's my opinion that by walking medical students through your opinions and understanding what the evidence is and being clear with being clear about which of the things that you're saying is what, is that evidence or is that my opinion? you're making a more informed choice on behalf of the medical student in terms of which road or what belief they're going to hold, even if that belief is, I don't know. And when we think about medical aid in dying, for example, one of the current debates that I actually was reading about this morning in the Globe and Mail was around folks who suffer from mental health conditions. And the definition of irremediable suffering, which is something that the Supreme Court made doctors decide. So somebody comes to you looking for medical aid in dying, you have to do a number of assessments. One of those things determines how severe their condition is. In the original legislation, mental health conditions were specifically prohibited from being part of the reasons why someone could be eligible for medical aid in dying. And that conversation is being held now, that a number of people are saying, well, look, I don't have a physical health condition, I have a mental health condition. And therefore, I still suffer in many of the same ways that people with physical ailments would suffer. And I have the same right to be able to choose my own fate as somebody else. Understanding that as a medical student and understanding different people's opinions on that subject is really important to informing your own future practice and understanding your own opinion. So I guess by this I might say that you and I might totally disagree on the issue of medical aid in dying, which, by the way, I don't think you and I have ever discussed, right? But the idea that you're talking me through how it is you feel and why it is you believe the way that you do helps me understand somebody else's point of view. Because I think one of the biggest dangers that we actually have in 2022 is only listening to people that agree with us. And I think that happens in all walks of life. And if I firmly disagree with you, I should be able to explain the point at which, why is that the case? And I think that's really important to communicate to medical students too.
Well, I think like the venue for a lot of that could be so innovative and creative and is happening in some spheres, like whether it's sort of debates or, conversations or, even like reading circles or book clubs. We're looking to do more and more of those with DMNB, just around some of those issues. So like, it's a safe place to say things, particularly for learners, but also have sort of some of that knowledge presented or the evidence presented, and then being able to like teach students to have kind of that framework or construct for how to build an informed opinion that, like, of course is going to be fraught with our bias and our values and beliefs, because everything we do is. And so, but how do you recognize that and know when that's the part of you that's showing up, as opposed to the objective part that, needs to present to patients and to families the facts and the evidence and all the options available. And then how do we reconcile that as humans kind of moving forward day to day? Because, I worry about that for the students a lot when, they're being called to do things that maybe they don't agree with. And then do we teach them how to reconcile that in a way that keeps their brain healthy and allows them to carry on? Because, much like yourself, you're going to come and work in New Brunswick, and we want you to work for a long time, but we want you to be healthy. And I want me to be healthy, and I want my colleagues to be healthy. And, right now there's so much to advocate for and so much to stand up for that sometimes you do feel tired. And so I wonder if that is something to talk about too, which is just, how do you not try to eat the elephant? How do you allow yourself to have, and I'll try to take the advice myself, how do you sort of take that niche and take that special thing, whether it's planetary health or, COVID stuff or mental health, when everything is interrelated, and not try to take on the whole beast, or feel that you failed if you don't move the huge needle, because you may not see it move in your lifetime, but hopefully you're creating a foundation for others to take up the torch.
Yeah, it's been said to me that medicine is a study in delayed gratification, because even if you do a lot of small A advocacy today for a patient, you might never see the result of that. Even if you worked really hard, you might see a backfiring of all the hard work that you do. There's no guarantees in life, but that's especially the case in medicine. So I think it can be tricky to try to work really hard every day and hope to see results. I grew up farming, and in farming, when you are getting rich off of $5 an hour out in a big field, staring into the sun most of the day, with the ophthalmologists really love, you see hay bales in the field, and you take those hay bales and you put them on a trailer and you take them to the barn and you stack them in the barn. And at the end of the day, you look out across the field and you say, I see what I got done today. It's very tangible. You know exactly what happened today. And that gives you a lot of motivation when it comes back to actually start again tomorrow. Medicine doesn't have that. There's no stacking of bales. There's no real feeling of done. There's a feeling of progress some days, but I don't think there's ever a feeling of, this is complete. Like I've done all I can do. So I think you have to get comfortable with that feeling. And I don't think we teach medical students a great deal about how to do that. We focus on resilience and yoga, maybe a bit too much. And in terms of how can you be satisfied with the work that you've done today and know that you've done a good job? I think another thing about trying to eat the elephant, beyond having some feelings of understanding the tangible nature and the intangible nature of the work that you do, is leaning on organizations. So it's understanding that you yourself are not in charge of affordable housing in St. John, although that might, in your case, make affordable housing in St. John go a lot better. It's really about, there are other organizations. So I'll go back to medical aid in dying. For those who felt really strongly about it, there was the Christian Medical and Dental Professionals Association, who did not want to be compelled to refer folks for medical aid in dying or medical abortion. And that's an organization that can engage with. There's the Canadian Medical Association, who spoke very differently on the issue of medical aid in dying. There's the New Brunswick Medical Societies, the College of Physicians and Surgeons. There's all these other organizations of hopefully like-minded individuals where you can find a community that helps to share the load and share the work that's there. And sometimes those even have staff members to help you with that, right? So it's that feeling that, you need to find your community. You need to find your folks. You're not always alone in the number of advocacy challenges that you have. And I guess the third thing associated with advocacy and what we teach medical students is that it's not always fun to be first, or it's not always fun to be early on something. So, going back to kids as a pediatrician or as somebody who's sending kids home from the hospital for the first time, we make sure that parents have a car seat. Car seats are pretty universal now. Many people are able to afford one, which is nice. Many people have them. And if you were to pick up a child that's, somebody else's, the first thing you think about is, how am I going to transport them? Even though you're staring at your vehicle, you're not thinking, I'm going to plug them in with a seatbelt. It's like, what are we going to do here? And that's sort of just a thing that we do now. Doctors were among the first to call for car seats in the 70s and the 80s, and they were really laughed at. Seatbelt is another one. Like, who would really belt themselves into a car? Like, what kind of idiot would suggest that I need to be strapped into my own car? Like, I've got metal, I've got glass.
In that really warm, nice back part under the window.
Yeah.
I know you're old enough.
Yeah, I spent my time staring out the back of a station wagon. Thank you, Dr. Gander. I appreciate that.
Hey, I'm older than you.
Hey, well, barely. If in spirit, not in body. But all this to say that being a doctor and working in advocacy is not always fun. You don't always have the Twitterati behind you, right?
No.
Sometimes grabbing a pitchfork and a lantern is... What's that?
Well, there's a lot of criticism, and it's sort of having that thick skin to realize, we also don't teach that, right? That it's not personal, but it can feel personal.
It feels it. Yeah, especially when you're a doctor who has left their professional, safe home environment of their office, which they understand and know, and has decided to pen a letter in the newspaper, which is not something they know that well. And they've really taken a leap of faith and courage to do so. And then, of all things, the doctors don't know that you shouldn't read the comments, right? And you take that personally. And so understanding that advocacy is often an uncomfortable thing to do, even when you're proven right? And doctors have been proven wrong many times, I should say. But when you're proven right about things like smoking and car seats and seatbelts and so on, you have to realize that while we think of those folks as brave advocates who did the right thing now, for a while they were, kind of bonkers to do what they were doing. And having that vision of being committed to the long game and understanding when it's best for patients and knowing when you're advocating just for doctors too. I think that's really important to know if you're advocating for yourself versus advocating for patients, and not to confuse the two, because many doctors have gone down that road and been confused on what they're advocating for, and it can be troublesome for them.
Well, I think sometimes doctors forget that we're not the general population, even though we feel close to the general population in a lot of circumstances.
Yeah, we feel like we can identify with people that, frankly, truly we cannot.
No.
And one of my favorite statistics that I always start my conversations, I do a lot of talking on physicians and finance, and specifically how doctors are paid. And one of the things I always start with is the median income of New Brunswickers. Because when we talk about money, We need to sort of think about, who is watching, what it is that's not only in the grocery cart, but what kind of car we're driving and those sorts of things. And so talking about the fact that, the median income of New Brunswickers is somewhere around $30,000, it's very hard for some of us to identify and truly understand what it's like to be in the position where you're in the grocery store and you don't have enough money to cover what's in the cart. And those are tricky. So we need to be cautious. It doesn't mean we shouldn't speak about nutrition. It doesn't mean we don't need to talk about affordable housing, because a lot of times those folks need an ally. But it's about being clear when you're an ally, and not somebody who's actually understanding or living those issues.
Well, I think CanMEDS has done a lot to recognize that these are powerful parts of the physicians that we're training and the learners that we're training. And so I think we are starting to see some of this stuff weaved throughout. But I really wanted us to have this conversation because I think that some of the most important things that you said were just what we can do kind of day to day as somebody who is day to day doing either small a, well, probably small A's advocacy, maybe big A advocacy, and how our students are always watching, and that there's an opportunity there to, like I've said before, not just teach them about the kidney, but teach them what it means to advocate for those kidney drugs that they can't afford, or what it means to join groups either locally or nationally that can help support your cause. One group that I'm very involved in, or have been in the past, is the Canadian Doctors for Medicare. And so that's such a big issue right now as we move into dental care and pharmacare in Canada. And you learn so much too. Like, you learn those facts. You don't have to reinvent the wheel. Maybe you're part of a group that's already created resources that you can reference. The Canadian Pediatric Society is excellent for that. CMA, MBMS, people like that. So I think those are some awesome take-home messages for our faculty and the students who are listening too. I mean, I hope it's a license to open that conversation with faculty and say, like, I'm really concerned about planetary health, and like, has anybody noticed that there's no recycling cans, here, there, or anywhere? Or like, why don't we compost? Which is a simple example, I know, but, or like, what are we doing about PPE now that COVID is underway to a degree? Like, did we do the right thing? Should we look back and learn? And those can build research projects or QI projects, or things that people might feel even more comfortable with because they're more traditionally part of the curriculum.
Yeah, so if I'm a student or a member of faculty, I think that's a really important point. So if you're concerned about climate, there's so much out there on metered dosed inhalers. There's so much out there on waste in the OR and how much we're throwing away. There's so much out there, and how do we get rid of the needles that we just put in the magical yellow boxes that someone else just takes care of, and they sort of disappear. We don't have to think about them again. So I would encourage everybody to find an issue that they're passionate about, and then just look at what's already out there and what's already been done, and how they might amplify the work of others, because it's a good place to start. Thinking about Canadian Doctors for Medicare, I think about Dr. Danielle Martin, wrote a great book called Better Now a few years ago. I think that's actually great and pretty easy reading, actually, for a lot of medical students, because they really understand a lot of the issues that are there. And that's really
it goes chapter by chapter, issue by issue. It's so good.
Right on. Yeah. It talks about you can, if you're truly don't care about climate change, you skip that one and you move on to the other ones, right? Like, you talk about housing or whatever. So I just think there's easy references out there for people to start with. They don't have to sort of stick around and say, well, how do I be an advocate, right? There's lots of work that's already out there, and hopefully lots of like-minded individuals. And if they're not around you, they're probably not far. And I think the key is connecting with those who you know and trust, and say, like, hey, I'm really interested in this issue. Do you know of anybody that's interested in that too? Or do you know of an organization that's working on that? And the Canadian Pediatric Society is a great one for, if they haven't had it actually as a position statement or a policy, they can often point you to the organization that has. So I think that's it's helpful to start from somewhere, and most importantly, to realize that you're not alone in whatever issue that you're really interested in.
Did we cover all the things that you wanted to cover, Andrew? Because you were so prepared for our podcast today.
You know what? 90% of life is I guess 90% of life is showing up. Maybe it's not. I think chance favors the well prepared. That's the quote that I'm going for. Oh, I think so. Right. So I think the role for faculty is to be aware of what's current and hot and interesting. And I think it's trying to model the small a advocacy. And if you do have a role with the college or with the medical society, or a role with a local community group that's really passionate about shuffleboard, I don't know, that you talk about your passions and you talk about your issues with students. Because students will learn, I think there's the bit there that students will learn 1/3 of their medical training from their patients, 1/3 of their medical training from their colleagues, their classmates, and 1/3 from you. So if you make up a full third of that in whatever you're teaching, both clinically, just realize that your students are learning a lot more from you than just the physical exam or just the way you take a history. They're learning life too.
Amazing. I think we should end with that, Andrew. Thank you so much for coming today to the podcast. I think I said a half hour. It's been about an hour, but it's always a pleasure. And it sounds like we have a whole laundry list of things to catch up on. And I so hope that the match results are in your favor next week and that we see you back in New Brunswick.
We'll hope so. I'm crossing fingers and toes.
Hey, maybe that means you get to come and do peds with me. Oh, fun.
I wouldn't want to distress your poor pediatric
St. John
patients,
kids are the cutest.
I bet the St. John, I've heard that, the St. John kids, I've mostly heard that from other Johners, but yeah,
all right. All New Brunswick children are cute.
They're beautiful. True. They're beautifully bilingual. They're beautiful. Well, thank you, Dr. Gander.
Yes, thank you so much. And we hope to see you soon.
All right. Bye.
Take care. Thank you for listening to the Fac Dev Lounge podcast. Please leave us a review on iTunes, YouTube, or SoundCloud, and even a comment on some ideas for future podcasts. Thank you very much and have a great day.